Hello, everybody. My name is Lynn Sickwiland, and I'm a member of the Public Education Committee of ADAA. That's the Anxiety and Depression Association of America. Welcome to our webinar, Does Your Child Have Anxiety or OCD? How can you be supportive and also demonstrate your belief in your child's ability to cope? And our presenter is Dr. Eli Lebowitz. These webinars are presented by the Anxiety and Depression Association of America, which is the leading nonprofit organization in the field of anxiety and depression. Our mission is to improve diagnosis and promote the prevention, treatment, and cure of anxiety, depression, and stress-related disorders through education like this webinar, practice, and research. Please take advantage of all the resources on the website ADAA.org. You will find a great list of treatment providers. Just click on Find a Therapist from the top of the homepage, as well as a free peer-to-peer online support group. Find the link by scrolling down the homepage. If you have a question after watching the webinar, you can send an email to ADAA.org. And you can support ADAA by making a charitable contribution on the website. For our live audience, take a moment to find the question and answer link. So you can type questions for our presenter. If you're on a laptop, look at the bottom of the screen near the center. If you're on a smartphone, tap anywhere on your screen and you should see a menu at the bottom of the screen with a question and answer link. Feel free to type in your question anytime. And if we don't get to your question, we'll do our best to address it on the website. I'm really happy to introduce our presenter. Professor Eli Lebowitz studies and treats child and adolescent anxiety at the Yale School of Medicine Child Study Center, where he is the director of the program for anxiety disorders. His research focuses on the development, neurobiology, and treatment of anxiety and related disorders, with special emphasis on family dynamics and the role of parents in these disorders. Dr. Lebowitz is a leading researcher in the field of childhood and adolescent anxiety, but he's also the father of 3 great boys. So let me turn it over to Dr. Lebowitz.
Okay, thank you so much, Lynn. It is an honor and a pleasure to be here. Thank you to everybody who's joining us from so many places. I only got a glimpse of some of the places in the chat, so it's really wonderful to have such a broad group joining. And thank you to ADAA for facilitating this encounter. I have been honored to be a member of ADAA for many years at this point and strongly encourage anybody interested in this area, whether as a patient or family member or professional provider, to join this really amazing organization and to make use of all the wonderful resources that ADAA makes available. So our topic today is childhood anxiety and obsessive compulsive disorder. I'm going to start by briefly saying just a few words on what these problems are and what they look like, and a little bit of what it's like to be a child who's coping with a lot of anxiety in their life. And then I'm going to focus more on the issue of what can be done to help child or adolescent overcome these problems, because the answer to that is there is a lot that can be done. There are really no problems in the field of mental health, whether that's psychiatry, psychology, really the whole area of mental health. There are no problems that are more treatable than anxiety disorders. And the world is just full of children who used to have an anxiety disorder. And so this is really a hopeful area. Work is not always easy, but it can be done. And so I want to talk a lot about how we can help children to overcome, and in particular to focus on the role of parents in helping children overcome anxiety problems. So jumping in, when we talk about anxiety disorders, we're actually talking about a range of different problems that often co-occur together with each other. But what we have on the screen now are really the most common anxiety disorders that we diagnose or see in children and adolescents, and actually in adults as well, because anxiety is exceedingly common in adults as well, and when left untreated, will often persist from childhood long into adulthood. So what are those problems? We have our phobias, which, as everybody probably knows, are strong, irrational fears of just about anything. Anyone who wants to really waste a day of their life can just Google things that end in phobia, and you'll see that some people love nothing more than to find the Latin name for something or the Greek name for it and tack on the word phobia at the end. And you could have a phobia of anything, but some things are much more likely to be the focus of a child's phobia. Things like the dark, storms, animals, large animals or small animals like bugs, heights, things like that. Basically the things that posed a risk to our survival and our well-being over the course of our evolutionary history. And phobias, even though they are so specific to a particular object or situation, can lead to widespread impairment in a child's life because of all the avoidance that surrounds the phobia. So for example, a child who is afraid of sharks might not actually encounter a shark very frequently in their life, but might suffer significant impairment because of the fear of seeing anything that even reminds them of a shark, like a picture of a shark, or they think that taking a shower is a way to meet a shark. And so you might end up with a lot of impairment, even though the focus of the phobia is quite narrow. And then we have panic. Panic disorder is really characterized by having recurrent panic attacks. And panic attacks, for those who have, those fortunate among you who have not experienced a panic attack, it's a little bit like having a wire trip in your brain. And you're just awash in these tremendous waves of anxiety that crash over you with dramatic physical arousal, that racing heart and sweaty palms and shortness of breath, and also with very frightening thoughts that go along with it, like the fear that I'm losing my mind, or perhaps I'm dying, maybe I'm having a heart attack. It's an intensely uncomfortable experience. It's not a particularly dangerous experience physically. Your body is really not working any harder when you have a panic attack than it is when you run a quick sprint. So physically, it's not dangerous, but it's so uncomfortable that people who experience panic attacks will often become very impaired by their determination not to experience another one. And so, for example, if I had a panic attack outside, I might not want to go outside. If I had one on the bus, I might not want to get on a bus ever again. And so you could end up with a lot of impairment, even though the attacks are relatively brief, usually lasting only a matter of minutes. The impairment can last for years and severely disrupt a person's life and their ability to function. And closely linked to panic disorder is agoraphobia, which is the fear of various situations because of the thought that I might experience physical symptoms relating to anxiety in that situation and not be able to avoid or to escape the situation, or maybe I'll be humiliated because other people will notice that I'm having these symptoms. This can contribute to a lot of problems. For example, it can lead to a lot of school absenteeism. There's a child who fears they might have panic symptoms, for example, in the classroom, might be very reluctant to go to school because they know they can't just stand up and leave a classroom whenever they want, or that other children are around and they notice. And so again, we end up with a lot of impairment relating to the problem. Continuing quickly across this cycle or circle, generalized anxiety is really a name for chronic interfering worry. And that can be worry about just about anything. It might be health concerns. It might be perfectionism and the worry that I didn't do something well enough. It's a little bit like having an antenna on your head that's tuned to pick up things to worry about and then to just run with it, and your brain just churns away with all of the thoughts relating to your worries. Maybe you're a child and you heard your parents arguing, and then you lie awake all night thinking about the meaning of the argument. Are my parents going to get divorced? Who will I live with if they get divorced? How am I going to move house? And your mind is going 30 steps forward from the simple argument that your parents actually had. But in the meantime, you're losing sleep and you're feeling distress. And then the next day, you're also tired and your attention is going to lag. And so that kind of interfering and difficult to control worry can take a tremendous toll on a child's mental health and also on their physical health, because it wears down your body as well, so that you're more fatigued, you have more aches and pains, you're more vulnerable to common illnesses, and can really impact somebody's existence dramatically. Social anxiety, also called social phobia, is really a form of extreme shyness. It's the over preoccupation with other people's judgment of you and the fear of being in situations in which other people might evaluate you and might evaluate you negatively. So that might be, for example, not wanting to talk to other people, whether other kids or maybe other adults, not wanting to raise your hand in class, not attending school functions. It can lead to a lot of self-isolation. And it's important to remember, children with social anxiety, they're not socially disinterested. They may long for social interactions in which they feel comfortable and get along with other kids, but they may put a lot of energy into avoiding those situations because of the fear that the situation won't go well and that they'll make a mistake, mess up somehow, make a fool of themselves, etc. One problem that is related to social phobia is selective mutism. And that's a phenomenon in which a child who is able physically to speak and does speak in certain situations will completely avoid speaking in other settings. So maybe they don't speak at all in school, for example, so that it looks like they're actually mute, although of course they're not, and then they may go home and be quite talkative. Separation anxiety is the fear of being separated from your caregivers, attachment figures, generally parents. That can be the fear of something that will happen to you when your parents are away, like maybe I will get lost, or a burglar will come into the house, or I'll get kidnapped, etc. It can also be the fear of something that will happen to my parents when they're not there, like maybe they'll get in a car accident and never come home. And this can lead to strong resistance to separation and clinginess and trying to avoid being away from parents at all costs. And finally, I included on this list obsessive compulsive disorder, which is characterized by some combination of obsessions, which are intrusive thoughts that come unbidden and unwanted into your mind. And you can't stop them from coming, but they're just there and tormenting you. And the other element is compulsions, which are ritualized behaviors that you engage in, often with a really strict pattern and structure to them that you do. And very often you do the compulsions in order to ward off the obsessions or to alleviate the distress that the obsessions are causing. Sometimes there'll be what seems like a logical link between the obsession and the compulsion. So for example, a common obsession is fears about or thoughts relating to contamination, germs, things like that. And you might have a compulsion that goes with it, for example, hand washing. And you can see a link between the contamination obsession and the hand washing compulsion. Other times there won't be that logical link. I might have a thought that I will do something bad. That's another common obsession, is that I will harm somebody or even harm myself. And then you might still have a hand washing compulsion, even though that doesn't make as much sense, but it serves to alleviate the distress that the obsessions cause. And even though most people, including most children, can recognize that their obsessions and compulsions are irrational and don't really make sense, they still feel strongly compelled to do them and are unable to stop. And sometimes this can grow to quite a large degree so that it takes over a lot of your day, where you spend so much of your time thinking your obsessive thoughts or engaging in your compulsive rituals. It's important to note that anxiety disorders will often be comorbid or co-occur with other mental health problems. They'll often predict the onset of depression, for example. They're also often comorbid with substance problems. Sometimes children and adolescents in particular will develop a substance-related problem as a form of self-medication, because they realize that using a substance, whether alcohol or marijuana or something like that, might help to alleviate the anxiety that they're always coping with. And so that can lead to a spiral of growing substance-related issues. And anxiety disorders are also extremely comorbid with other anxiety disorders. In fact, it's actually more common for a child to meet criteria for more than one anxiety disorder than it is for just one anxiety disorder. So the child who presents, for example, with separation anxiety, that might be their chief kind of complaint that they are reporting. But if we check, it's actually more likely that they have at least one other anxiety disorder, maybe generalized anxiety or social anxiety, than that they only have that separation anxiety. And I wanted to use a metaphor to try to capture a little bit of what it's like to live with a lot of anxiety in your life. And it's a metaphor that stems from a previous period in my life, many years ago when I was in the military. I was in the Army. And one of the things, I was an infantry soldier. one of the things that you're taught as part of your training is how you should behave if you find yourself in a minefield, how you should walk essentially in order to, optimize the likelihood that you'll make it out of the minefield alive. And I think it captures some of the aspects of what it's like to be a child with a lot of anxiety, where your life feels like you're living in a minefield, where every step and everything you do might lead to some catastrophic negative result. Now, the truth of the matter is you don't really need this training. All you need is a little bit of common sense, and you'll probably do what the training tells you to do anyway, because there's really two changes that you would expect to see in somebody if they are in a minefield, if they find themselves in such a fraught situation. One thing is, when you're in a minefield, you're going to take as few steps as possible. You don't take extra steps because every step could be so dangerous, right? So, if I'm at home in my backyard and I see a pretty flower, or I see a rabbit or something like that, I might wander over to get a closer look because it's pretty or cute. If I'm in a minefield and I see a rabbit, I don't wander over. I hope the rabbit makes it out of the minefield alive, and I wish it good luck, but I don't wander over because it's not worth it. It's not worth the risk. And this is often a pattern that we'll see in anxious children, is the way that they will often forego any number of potentially positive experiences because of the risk of a potentially catastrophic experience. So for example, could I have fun on the school trip? Sure, maybe. Will I go on the school trip? Definitely not, because it could also be catastrophic. Maybe I'll make a fool of myself, maybe our bus will crash, maybe there'll be a tornado and we'll all get swept away, et cetera, et cetera. The other change that we'll see in somebody who's trying to walk in a minefield is that they're going to show a preference, I would say a fanatical preference, if at all possible, to step where you've already stepped, because the familiar is infinitely safer than the untested ground. Of course, what you really want to do in a minefield is step where somebody else has already stepped for you. But if that's not possible, you're going to want to put your feet in exactly the same spots that you put them before. So if you went too far in one direction, you're going to want to walk back and put your feet in exactly the same places. And you see this in anxious children too. The preference for the repetition and the familiar and the aversion to novelty and to change, because everything unfamiliar feels infinitely more dangerous than anything that is familiar and tested and that I know is safe. So we've been talking about what these anxiety problems are and a little bit about what they're like, but let's start talking a little bit about treatment. And for many years now, for several decades now, there have really been two main evidence-based approaches to treating childhood anxiety, including obsessive compulsive disorder. And these are both treatments that have proven efficacy and that have been tested in multiple randomized controlled trials and that we know work for a significant proportion of children who get them. One of those is cognitive behavioral therapy. This is a psychological treatment, often called CBT. You may have already heard about this or be familiar with it. This is a treatment that teaches children to identify their anxious thoughts as stemming from anxiety, to challenge those thoughts, and to practice what is often called exposure, meaning to practice purposely putting themselves in proximity or contact with the things that their anxiety would normally make them avoid. And doing that in a systematic way can really be extremely efficacious and helpful in overcoming anxiety. And a third, alongside the cognitive part and the behavioral part of exposure, many CBT protocols will also teach children physical regulation tools for calming their body, like breathing exercises, muscle relaxation, and the like. The other evidence-based approach that has been supported by many clinical studies and that has been around for several decades now is pharmacological treatments or medications. These are usually referring to medications within the group called selective serotonin reuptake inhibitors, or SSRIs. Prozac is a famous example of SSRI, but there are many, many other particular names, and I don't want to get into particular brand names of treatments. The one thing, or maybe a couple of things to know about medication for anxiety. One thing is it's sometimes confusing to parents because these treatments, the SSRIs, are actually called antidepressants rather than anti-anxiety, and that can be confusing. But if your child has anxiety and the doctor is prescribing an antidepressant, it's not because they are confused or haven't understood that the child is coping with anxiety rather than depression. It's simply that these medications are used for both depression and anxiety. And in fact, the group of medications called anti-anxiety medications are paradoxically and confusingly less recommended for treating anxiety. And the antidepressants are really considered the frontline treatment of choice. And so between the two of them, we can help a great number of children who struggle with anxiety. But not every child is going to respond well to these treatments. Some children will receive CBT and not get enough benefit out of it. Some children won't even try it in the first place. CBT is a challenging treatment that requires a high degree of motivation and collaboration and engagement on the side of the child, and that's not always possible. Other children may have a verbal language difficulty that makes it hard for them to engage directly with a therapist and discuss their problems and learn these tools. And so even though these treatments exist, they are helpful for many children, but not helpful for all, which means that we are always looking for additional ways to help anxious children, given the incredibly high prevalence of anxiety problems. And these really are the most common mental health problems throughout life, really, and certainly in childhood and adolescence, with current estimates suggesting that approximately 1 in 3 children experiencing a clinically impairing anxiety disorder at some point before they reach adulthood. So we're talking about really, really high prevalence. Given the really staggering prevalence of these problems, we're always looking for additional ways to help anxious children, which leads me to another strategy for intervening, another treatment for addressing anxiety in children, which is a parent-based treatment. And I want to set the stage for understanding the role of parents in child anxiety. And then from that, for understanding the treatment that will be, the parent-based treatment that we'll be talking about, I want to set the stage for that by showing you this slide that has a lot of cute, sweet pictures on it, but these are not just a random collection of pictures. There's actually a theme to them. And the theme is that these are all pictures of mammals. And in fact, they're all pictures of mommy-child mammal pairs. And the point that the slide is trying to make is A, that we fit into this group because we as human beings are, of course, mammals as well. But more importantly, that our mammalian nature actually has important implications for understanding how anxiety works in children and the role of parents in particular. Now, why is our mammalian nature so important? Well, it has to do with the fact that mammals are born not very well prepared for life. A young mammal is born not able to feed themselves and not able to protect themselves. In fact, left to their own devices, a young infant mammal is not going to survive without some help from caregivers. And what that has led to is a reality in which when a young mammal, including a human being, a baby or a child, when they are scared, their response is actually meaningfully different from an adult member of the species response, from an adult's response, right? If you were to, say, frighten an adult, they would respond with your classic fight or flight response, right? They may run away from you, or they may try to engage you, maybe attack you, fight back, things like that. But if you were to do the same thing to a baby, they would do neither of those things, right? If you were to walk up to a baby and scare them, they would not attack you because they can't, and they would also not really run away because they can't. So what does a young mammal do when they're scared? they look to their caregiver. They rely on their caregiver. They let the caregiver, usually that means the parent, they let them know that they feel danger, that they feel threat and fear, so that the caregiver, the parent, can step in and help them. By the way, I'm not encouraging anybody to actually do the experiment of scaring little babies, partly because that would not go over well, and partly because we all know what would happen, but also because inevitably psychologists have already done that experiment for us. There is very little that psychologists like better than to come up with really diabolical, devious experiments to prove what people generally already know. And so the experiments that I'm actually referring to here were conducted by a very famous psychologist called Harry Harlow, decades ago now, like 50, 60 years ago in Wisconsin. What he did was to take baby monkeys and to raise them in a cage, not with their real monkey mother, but with these two so-called surrogate mothers. These were dolls, one of which was a soft terry cloth, tactile kind of soothing mom doll, and the other was a wireframe doll that wasn't as fun to hug, but that would provide food. And he wanted to know, who would the baby monkey become attached to? Now, the answer is that it became attached to the soft, cuddly surrogate mom. But what's interesting for our conversation and for understanding fear is, how did Harlow test who the baby monkey was attached to? Well, he did a simple thing. He scared the baby monkey, because he knew that baby monkeys, just like baby people, when they are scared, they will signal their caregiver. You can actually see this for yourself in a very brief video clip that I'm about to play.
Now, in this experiment, this is the apparatus we use. That looks diabolical. That's just the way the baby monkey feels about it. Flashing eyes, loud sounds, moving mechanical parts, all of these things are designed to frighten a monkey. Now, here we have a peaceful, resting baby monkey. Let's find out what his reactions to his mother are when we frighten him. He's scared, all right, and he does what any child will do in a similar situation. He runs away. It's more than running away. He was running to his mother, to touch her, to drive away his fear. Contact with the mother changes his entire personality. Look, now he's actually threatening the diabolical object. This gives us part of the picture of the strength of infantile love.
So what is this teaching us? It's really making the point that children's natural response to fear is a social response that's oriented toward their caregiver, toward their parent. And it's not only children who are hardwired and programmed to respond to fear by signaling the parent, it's also parents who are programmed and powerfully motivated to notice when their children are scared and to step in and provide those critical functions of protection. And once the child is safe, also regulation and soothing. So what does it all mean? Everything we've been saying, what it means is that in young mammals, including children, fear is really a social response. It is an interpersonal response with a child signaling a parent and a parent responding and protecting the child. Now, if we accept that, then it also makes sense that we should accept that if any child has a disorder, has a problem, where the heart of the disorder is chronic and inappropriate activation of the threat detection system, meaning the child has an anxiety disorder, then inevitably what is going to ensue is chronic inappropriate activation of that interpersonal system of signaling and responding, of a child signaling their fear to the parent and the parent stepping in to alleviate the child's fear. Meaning that anxiety disorders inherently involve parents. And in fact, when we look at what actually happens in the family of a child with an anxiety disorder, what we see is that it's not only the child's symptoms. It's not just that the child has anxious thoughts, or the child's body is dysregulated, or the child's behavior is avoidant, it's also that interpersonal aspect playing out through a process that we call accommodation. The parent becoming entangled in the child's symptoms through their attempts to help the child not feel anxious or to alleviate the distress relating to the anxiety. Accommodation can take many forms. For example, when a child has social anxiety and is anxious about talking to people, the parent may be speaking in place of them. Maybe they're at a restaurant and the child is uncomfortable telling the waiter what they want to eat, and so the parent speaks for them. Or maybe the child has separation anxiety and is anxious about being alone at night, and so the parent accommodates by sleeping next to them. Or maybe the child has obsessive compulsive disorder and the parent engages in rituals and in compulsions together with the child. Maybe they're doing repeated checks in the house to make sure that things are okay. Maybe the parent is washing their own hands because of the child's contamination fears. And sometimes what we'll see is modifications to the whole family routine, like the need to adhere to very rigid timetables because any change will stress the child and lead to anxiety. Maybe they're driving special routes so as not to drive down the street that the child is afraid of. Maybe they're coming home early from work. Overall, what we have learned through a lot of research on accommodation is that it is almost universally present among parents of anxious children. If you are the parent of an anxious child, then it is almost inevitable that you will find yourself doing some accommodations, and usually frequent accommodations daily and often many times a day. And this is true throughout the world because we have studied this in almost every region, many continents and countries around the world. And we always see somewhere between 95, 6, 7, 8, or even 100% of parents of anxious children reporting a lot of accommodation. But we've also learned something else of critical importance. And that is that even though these accommodations are well-intentioned and your attempt as the parent is to help the child be less anxious, what actually happens is the reverse, meaning that as parents accommodate more, children actually tend to get more anxious over time rather than less. And this is really important to know because it makes sense of the very frustrating experience that many parents will be living through, which is I'm doing so much, pouring so much time and energy and resources, sometimes even money, into accommodating my anxious child, but they're not getting better. They're just getting more and more anxious. And it's not just that the symptoms get more severe, but the impairment, the disruption to daily life grows as well as the child gets more anxious. And not only that, but high levels of accommodation actually predict poor treatment outcome, worse treatment outcomes for the two treatments that I described previously, cognitive behavioral therapy and even for medication. So children who are more heavily accommodated are less likely to benefit from those treatments. So having said all of that, what can we actually do about it? Well, what we have done is to take this interpersonal understanding of the way that anxiety actually works in a child, which is meaningfully different from the way anxiety works in adults, and this understanding of the role of parents in accommodating their child's anxiety, and translated that knowledge into a parent-based treatment for child anxiety called SPACE, which stands for Supportive Parenting for Anxious Childhood Emotions. And SPACE, unlike CBT or even medications, does not require a child's direct involvement or engagement with therapy at all. It's just the parents who are coming to treatment and learning how to change their behavior to help their child overcome the anxiety disorder. And there are really two main changes that parents learn to make in their own behavior in SPACE. The first is they learn to respond to their child's anxiety in what we would call a supportive manner. The second, I'm going to define for you exactly what we mean by a supportive manner in SPACE. That's the first of the two changes. The second is they learn to systematically and in a warm, loving, and accepting way to systematically reduce the accommodations that they have been provided. And it turns out that when parents are able to make those two changes in a consistent and systematic way, then children can overcome even serious anxiety disorders, and even without engaging directly with a therapist at all. So let's say just a few more words about what this treatment actually looks like. So first, I said that one of the big changes is learning to respond to the child's anxiety in a supportive manner. So what do we mean by a supportive manner? Well, a parent is being supportive in response to their child's anxiety symptom when they're responding to it in a way that gives the child two key messages. The first is a message of acceptance, of validation, of acknowledgement, really. It's as simple as saying to your child, I get it. This is hard for you, or this is frightening for you. This is scary or uncomfortable. It's a simple expression of acceptance and validation. And even though this sounds obvious, our intuition is sometimes to do the opposite. Sometimes as parents, when a child says something like, this is scary, we reflexively respond by saying something like, no, it's not, because we want our child not to be scared. But what we're not doing by saying, no, it's not, what we're not doing is accepting that that is their genuine experience at this moment. Maybe what we want to say is more like, it's not dangerous, or I'm not scared, or I wish you weren't scared. But when we say things like, it's not scary, then we're not being accepting. And sometimes we're not accepting in even harsher ways, like when we say, don't be a baby, grow up, don't be a sissy, things like that. And so the first element of support is showing acceptance. But that's not yet supportive. That's one of the two key ingredients. The second is a message of confidence. By this, I mean showing your child, telling them and showing them that you believe that they can handle feeling anxious, that they can cope with that, tolerate it, and survive it, and still be okay in the end. And this is also something that we don't always intuitively do. Our impulse to try to do whatever we can to alleviate the anxiety sometimes gets in the way of showing the child that we believe that they can handle feeling anxious. Now, when we put those two messages together, the message of acceptance and the message of confidence, that's when we get a supportive response, which can sound as simple as saying something like, I get that it's hard for you, and I'm sure that you can handle it. This kind of support, giving your child the message that you get it, but that you believe they can handle it, is one of the biggest gifts that a parent can give to an anxious child. Because the way that anxiety trips us up, the way that it really gets us, is by causing us to feel that we can't handle feeling anxious, that we need to avoid feeling anxious at all costs. And that's where all of the impairment stems from. When a child thinks, uh-oh, if I did that, it would make me so anxious, I don't ever want to feel that way, they're going to avoid that. And that's what's going to impair their function. And then they'll get anxious about even more things, and they'll be even more impaired. By showing your child that they can handle feeling anxious, that it's uncomfortable, that it's unpleasant, and you know that, but that you believe they can handle it, you can change their attitude toward their own anxiety. Remember that as parents, you are like a mirror that your child is looking into to see who they are. And if the mirror reflects to them an image of themselves as weak and vulnerable and helpless in the face of anxiety, then that's what they will believe, and they will become more impaired by anxiety. If the mirror shows them I'm a strong, competent child who can be anxious some of the time and yet still be okay, then they will start to believe that, and the role that anxiety plays in their life will shrink. So that's what we mean by a supportive message. It's that integration of acceptance and confidence. And that's one of those two big picture changes that parents make. The other had to do with reducing accommodation. And so you can see laid out on the screen now in a little bit more detail some of what goes into accomplishing that over the course of space treatment, starting with introducing parents to the rationale for the treatment and setting the stage for it, working on those supportive messages, and then putting in a lot of work to actually identify the ways in which parents are accommodating, choosing specific focus points for which accommodations we're going to be reducing. You don't need to stop all of the accommodations all at once. You can pick one thing And even that you can do gradually. So you might make a clear, specific plan for how much you're going to reduce the accommodation. And critically, we're going to let the child know in advance about the change that you will make in your behavior, so they're not confused by it, so they understand why you're no longer providing the accommodation. So they understand that it's not because you're mad at them or fed up with it, but that this is your way of helping them. And space also includes tools for helping parents to cope with the more challenging responses on the part of the child that you might encounter. Because it turns out, to absolutely nobody's surprise, that when you do start reducing accommodation, children don't always respond with immediate gratitude. Some of them may become frustrated by it, even angry. Some might say things that are hard to hear, like, you don't care anymore. And those are difficult things. And so space includes a set of tools for helping parents to cope with those situations in a supportive manner while still pursuing those goals. And as I said before, when we're able to pursue those goals of and to achieve them really, of reducing accommodation and being supportive, we can overcome even serious anxiety disorders. What you see on the screen now are results from a large randomized controlled trial that compared outcomes for children with serious anxiety disorders who were randomly assigned to receive either cognitive behavioral therapy, in which they met directly with a therapist for 12 sessions for CBT, or they were randomly assigned to space, and they never met with a therapist, but the parents did, and learned to make these changes of support and reduced accommodation. And what the data show is that children who received space were just as likely to overcome their anxiety disorder than as were children who received CBT. In fact, we had complete non-inferiority for this entirely parent-based treatment as we did for children who received CBT. Here you can see more outcomes from the same study, and space has been tested in additional clinical trials, and the evidence base for this treatment just continues to mount all the time. And so with the really 2 minutes left before we take some questions, if there are from the audience, I do want to mention that we're not only learning about the effects of treatment in terms of reduced anxiety, we're also learning more and more about how this treatment works, including by using brain imaging, specifically in this case, functional magnetic resonance imaging, or fMRI, to learn about what changes in a child's brain as the parents go through this treatment. And what we see is that following space relative to other treatments, following space, children are less dependent on their parent for anxiety regulation at the neurological level. So that if you compare, for example, their brain response to a scary picture, say, when their parent is there, relative to when the parent isn't there, following space, we see reduced dependence on the parents, and their brain is better regulating the fear even without the parent being there. And this difference between when the parent is there and not there directly correlates with the level of accommodation that parents and children are reporting in their daily lives. I think that's really fascinating in terms of seeing almost what you might think of as a biomarker for accommodation and a neurological signal for how a completely parent-based treatment can actually change the function of a child's brain. And so I'm going to leave it at that. I'll just mention some resources for those who want to learn more about the space, whether as a provider or as a potential patient or otherwise. There's a website, that's spacetreatment.net. You can find many resources there, including links to articles, books, podcasts, etc. You can find a list of providers who are trained in this method, by which you can search by country or by state, and you can find information for how you can get trained if you are a therapist who does treatment for anxiety, how you can learn to do this treatment with your patients. And other resources, there's a Facebook page dedicated to space, which is facebook.com/space treatments, and there's a YouTube channel, and etc. These are 3 books that I would recommend for parents. I would highlight the one on the left, the blue cover, Breaking Free of Child Anxiety and OCD. And that is a book that really walks parents through how you can implement this treatment on your own with the help of the book. So I promised to leave some time for questions, so I'm going to stop there and just say thank you again to ADAA, thank you to Lynn, and to all of you, and I'm happy to answer questions if there are.
I think the questions are mostly related to how does one actually go about kind of doing this in a situation with a child with more severe symptoms. Could you give some examples of how parents, can begin to limit accommodations or help with this?
Yes. So first, I want to emphasize that the clinical trials focused on children with severe anxiety. You can use these tools even for also for children with much more mild anxiety. Maybe your child has subthreshold kind of anxiety or a little bit of anxiety. It still makes a lot of sense to use these tools. And by doing so, you may actually prevent the development of a more serious anxiety disorder. But our clinical research actually focuses on children with severe anxiety. So we can say with confidence that space can be implemented for children with really severe anxiety as well. Now, the key is in being systematic and taking a focused, systematic, and gradual approach. So what we would do in terms of reducing accommodation, what we do is start by really trying to understand all the different ways in which accommodation is playing out for this particular child. And there may be many. We work on developing in the treatment what we call an accommodation map. All the different ways throughout the day in which parents are accommodating. Having done that, we'll pick one specific target to focus on, because when a child has severe anxiety, there can be a ton of accommodations happening, and trying to do it all at once is just impossible. But you can pick one thing and you'll look for a target, a specific accommodation that's happening frequently. So maybe, for example, your child has generalized anxiety and you are answering endless reassurance-seeking, worried questions throughout the day. Your child is just coming to you again and again and again and asking you all these worried questions. You might focus on that, and you might make a plan that says, I'm going to limit that to, for example, only answering 5 questions per day. Now, to be very clear, the plan isn't that your child will only ask you those 5 questions. They may continue to ask you 100 questions on the first day and on the second day. The focus is entirely on the parent's behavior. And this is a really consistent message in space, is that we never try to directly alter the child's behavior. Telling parents you have to go and make your child do this, or you have to make your child stop doing that, is a recipe for failure. And it's a recipe for escalation and conflict, because you can't really make your child do things. And so we're going to focus entirely on the parent's behavior. So I'm going to make a choice that says, regardless of how many times my child asks me, I'm going to answer 5 questions. And when those questions are exhausted, I'm simply going to make that one supportive response. I'm going to say, as I told you, I know this is hard for you, and I know how worried you feel right now, but I don't believe it's helpful for you when I continue to answer, and I know you can handle it, so I'm not going to answer anymore. And then you really walk away from it. You give them some space, capital, lowercase, I should say, S, like real space, and you give them some time. Maybe you go in the other room. Maybe you take the dog for a walk, and you allow them to get through that difficult moment without the accommodation. And then when they are calmer, because you didn't do the accommodation, and their natural ability to self-regulate their anxiety has eventually kicked in, which it will, you then can praise them for getting through it. And you do that consistently. You can apply the same method for other serious anxiety disorders, for serious obsessive compulsive disorder. The key is in being systematic and in maintaining the focus on your own behavior, on the things that are under your control, rather than trying to force a change on your child.
And I wonder if it's in the same way, there's a number of questions about what to do when a child does not recognize that they're anxious or doesn't have the capacity to say what the suffering is about, but shows the other behavioral kind of signs of anxiety. How do you kind of cope with that?
Yeah, well, I would say that for a child who is either lacking insight into the anxiety or potentially is not able to articulate their anxiety in a verbal way, space is actually probably going to be almost the only effective psychological treatment, because it's actually really hard to do direct therapy with a child in that situation. Either they won't come to therapy sessions at all because they don't recognize that they have an anxiety problem, or they will come but are not able to make good use of it because of the difficulty in articulating the problem or in verbalizing it. In space, we don't actually need the child to be doing that. we are focused again on our behavior. So I'm able to say to my child, this is what I see. And this is my response. This is what I believe is helpful or unhelpful. Now, we don't need to use the word anxiety. It's okay if a child doesn't see it as anxiety. There's no special, sanctity to the word anxiety over another word that a child might relate to more. I can say this is uncomfortable. I can say it's stressful. I can say it's simply hard for you. I can say it's difficult. You don't need to get your child to, pledge allegiance to the idea of anxiety. But if you see that they are struggling and you understand it to be driven by anxiety, and you see that your behavior is being modified as a result of that, then you can still take the same steps without the need to get them to actually achieve that insight or articulate it in a kind of verbal way.
Yeah, and I guess there's some questions also about what happens, like if a child tantrums in response to this intervention or to limit it. And there's also a few questions about when the functioning is really impaired and the kid or teenager, what do you do when you feel like you might need to take over for them?
Mm-hmm. Okay, so let's break those into two. So one was around the child tantruming. So I would say this, a certain amount of resistance on the part of the child to the parent not accommodating is predictable and to be expected. And for the most part, as long as that is within some reasonable boundary of what can be tolerated by a parent, the best advice that I can give is to actually ignore it, to allow them to have that tantrum, and to remember that anxiety doesn't only manifest as fear, it also manifests as anger. It always amazes me that everybody is so familiar with the words or the term fight or flight, and yet so many people seem to forget that literally half of that is fight. And what it means is that just like anxiety can prime us for fear and for flight through feelings of fear, it can prime us for fight through feelings of anger, aggression, rage, and hostility and irritability. And so you can see that behavior not as your child suddenly misbehaving or being bad and resist the impulse to jump in and discipline them and teach them a lesson, but rather to be empathetic to the fact that you're doing a treatment that's hard for them. And they're allowed to tantrum in response. That's okay. You don't need to actually do anything about it. You can allow that to sort of play itself out. Now, if the child's anger and their kind of disruptive responses go beyond what is reasonably tolerable. So it's not just that they're having a temper tantrum, they're yelling, they're slamming the door, they're using some unpleasant words, but they're actually going beyond that. Maybe they're being physically aggressive at a point that is a real concern. Maybe they are being physically destructive to property at a level that is a real concern. Then we will use some of the additional tools that are part of the space treatment. For example, we'll often rely on the help of other people in the child's environment. So one of the most effective things that you can actually do to help a child be more inhibited around that kind of physical aggression or destructive behaviors is to involve some other people, to get help from your relatives, grandparents, aunts and uncles, friends, etc., and have them speak to the child. They can say something really warm and supportive, like, I know you've been really struggling with your anxiety. And I also know that your parents are taking these steps to help you. And I know that that's hard, but I also heard from your parent that yesterday you broke their television, for example, or you punched one of them or something like that. And that's never an okay behavior. And using that kind of supportive response from other people actually is a powerful deterrent and inhibitor to that kind of behavior. But it's a response that is not punitive. It's not, we're mad at you and so we are, taking away your TV rights or your privileges or yelling at you or lashing out in response and hitting you back or things like that. We're using a powerful intervention that is non-punitive. I do want to say that for providers who are thinking to do this, it's really important to get more in-depth training than I'm able to provide in a quick answer to a question on a webinar. And so I would really encourage, if you're a provider, to really pursue training in space. And if you're a parent, I would say at the very least to read the book that I mentioned, Breaking Free of Child Anxiety and OCD, where you'll get a much more in-depth description of how to use those tools.
Yeah.
In terms of
Many of the parents are asking very specific questions about their child that we can't really kind of answer in this, but can talk about the general principles.
Yes, and I'm sorry that we're not able to give really, really in-depth kind of personal consultation for a particular child, but we do have to be also both ethically responsible and you know, there's limit to what we can reasonably do in this kind of a forum. But in terms of the second question that you mentioned, where a child's function is really significantly impaired, I mean, I think it would depend. In some situations, the impairment is at a level where a child will require a higher level of care. And so maybe that would mean things like in a more intensive outpatient kind of setting. Sometimes it actually means hospitalization in a more residential treatment program. There are such situations, and again, without more specifics, it's hard to say, is this a case for that or not? That is one scenario. But actually, even when a child is really significantly impaired, and in fact, I would say the more significantly impaired a child is in their day-to-day function, the more likely it is that there is a lot of accommodation surrounding that impairment. Because in a child's life, there's sort of a seesaw between what the child does and what the parents do. And so the more impairment we see on the child side, often the more accommodation we see on the parent side. So taking a good look at that, what in my behavior is enabling or facilitating the level of disruptive function or impairment in the child side might point to some really important potential targets for accommodation reduction. But determining which is a situation for that kind of parent-based treatment and which is a situation for a higher level of care would require a more in-depth assessment together with a mental health professional.
Yeah. And how exactly does changing the child's behavior, I mean, changing my behavior, lead to changes in the child's behavior? What is it about how that works?
So the reason I think that this works as well as it does is that in a sense, a child is equipped from birth really with two systems for anxiety regulation. One is more similar to the anxiety regulation system that adults have, the capacity for self-regulation. The other is the interpersonal system that I was describing, the attachment-driven, accommodation-driven system that relies on the parents' involvement and intervention. Now, as a child grows older, away from infancy and toward maturity, what we will normally see is a shift in balance so that they become less dependent on the parent and more self-reliant in reducing their own anxiety. However, when a child has elevated anxiety, when they have an anxiety disorder, that natural transition to self-reliance can be disrupted so that they remain very stuck on relying on the parent's accommodation and are not practicing the development of their own self-regulation abilities. By systematically and in a supportive way, reducing the parent's accommodation, what we're facilitating is more development of the child's own anxiety regulation capacity. It's a little bit like how if you have a child who is born with, let's say, weak muscle tone, then physical activities will be harder for them. Starting as a baby, like turning over, sitting up, learning to stand and walk, etc. These things will be harder for them. However, it's not that they lack that capacity entirely, it's more challenging for them. Now, if you step in as the parent and always carry this child because you see that walking is harder for them or sitting up is harder for them, if you're always doing it for them, then their muscles will remain weak and it will continue to be hard for them to learn to walk and function independently. And so a better advice would be to allow them to push through that, and maybe they will flop over more times and maybe they will struggle with it, but they will also learn to walk independently. By reducing the accommodation and by doing it in a supportive way, we're allowing the development of more self-regulatory capacities in the child, more independent anxiety regulation. What we're teaching them is that anxiety is not an experience to always be avoided at all costs because I can't handle it, but rather it's an experience to be tolerated and dealt with. And as they do that, they will become less anxious overall, because the less scared you are about being anxious, the less anxiety you're going to have. And so I think
so we're close to out of time, Ellie. So yeah, So thank you very much. I think there's last was question about whether this can be used with adult children, and I know that you're beginning to do some work in that area as well. So that was some of the other questions. I figure with ADAA we should say thank you and log off now. Thanks to everyone for watching the webinar. Please like it and share it, and then feel free to email your questions to webinars@adaa.org. Thanks again, and see you next time. Thanks.
Thank you very much, everybody.
Right.
And thank you, Ben, and ADAA.